Hi, and welcome to the Breastfeeding Medicine Podcast. I'm your co-host, Dr. Ann Eglash. I'm a clinical professor in the Department of Family Medicine at the University of Wisconsin School of Medicine and Public Health and a board-certified lactation consultant.
And I'm your co-host, Dr. Karen Bodnar. I am a pediatric hospitalist at Inova Children's Hospital and an assistant professor of pediatrics at Virginia Commonwealth University.
I'm also a board-certified lactation consultant.
This podcast is produced by the Institute for the Advancement of Breastfeeding and Lactation Education. Hi, Karen. How are you?
I'm great, Anne. How are you today?
Good. I'm excited to talk to you about our topics. I want to start, and I'm going to talk about mastitis. And I want to share a case of maternal mastitis that's associated with toxic shock syndrome due to group A beta hemolytic strep. So this article is entitled Maternal Mastitis and Streptococcal Toxic Shock Syndrome Risk from Breastfeeding Children with Scarlet Fever, a case report and literature review that was published in the Lancet Infectious Disease 2025, with the first author being Sonia Dahmen. One of the reasons I want to bring up this article is because we've been talking so much about mastitis being inflammatory, especially since the mastitis spectrum protocol came out through the Academy of Breastfeeding Medicine in 2022. And so we've sort of put aside this concept of mastitis being infectious, but we need to remember that there really are cases of true infectious mastitis. In the author's background, they talk about different ways that mastitis due to pathogens, I should say, can occur. Pathogens can get into the breast via blood vessels, which would be hematogenous spread. It can also occur, pathogens can get into the breast by ascending up through the milk ducts from the nipple up, or from direct injury to the breast through the skin. So I personally am convinced that I see ascending infections from dirty pump parts, which is one reason I advise people who are pumping to wash their pump parts after every use and not store pump parts in the refrigerator between sessions. And the reason I think that the pathogens are due to pump parts is because they're bacteria that we tend not to see typically in the breast tissue unless it's coming from an instrument or a device like Pseudomonas or Proteus. The goal of this study, of this case study and literature review, was to highlight the risk of severe group A beta hemolytic strep mastitis, particularly when breastfeeding a child who has scarlet fever. For people who are not aware of what scarlet fever is, it's basically a case of strep throat with a red rash and fever. And in this discussion, I'm going to use the term group A beta hemolytic strep, or I might say Strep Pyogenes, which are basically the same thing. The authors present a case of a 35-year-old mother who was nursing her 4-year-old child who was recently diagnosed with scarlet fever. And the child had not been treated with antibiotics, and the child was only nursing at night. She also had an older child who was diagnosed with scarlet fever a few weeks prior and had been treated with antibiotics. Her 4-year-old was having symptoms of scarlet fever with sore throat, rash, and fever when she developed left breast redness. And she was diagnosed with mastitis and took 3 days of ceftriaxone as an outpatient. And then on day 4, she became much worse. She became delirious and had signs of sepsis. So she was brought to the hospital via ambulance. And when she arrived in the ER, she was hypotensive. So had low blood pressure. Her heart rate was fast. She was tachycardic. And she was in severe pain. So she was admitted to the intensive care unit where she had multiple sequelae, including respiratory distress syndrome, thrombocytopenia, and acute kidney failure. They did a CAT scan of her chest and abdomen to see where this was coming from. They didn't find an abscess, but she had extensive connective tissue destruction in that left breast, which extended to the shoulder, but it didn't extend into the thoracic wall and was largely isolated to the breast capsule. She had debridement of the left breast with significant amount of Strep Pyogenes identified in the culture, and her breast culture was also positive for Strep Pyogenes. She therefore met criteria for streptococcal toxic shock syndrome, likely stemming from mastitis, which in turn occurred from the exposure to her child's Strep Pyogenes in his throat. She ended up having extensive necrosis of the left breast and with extensive intensive or extensive, I guess, wound management, they were able to reconstruct the breast, so she didn't have a mastectomy, and she left the hospital on day 34 doing pretty well. So she basically ended up having necrotizing fasciitis from group A beta hemolytic strep, which from my experience was the big reason why we began giving the chickenpox vaccine in our community after the vaccine came out in 1995. When it first came out at that time, there was some concern that we really didn't need a chickenpox vaccine because chickenpox didn't seem to be like a major illness. It seemed more of a minor childhood illness. But then we started seeing necrotizing fasciitis in children who had chickenpox at the time and then were also exposed to strep. So that led many of us to say, okay, this is clearly an issue. We have to make sure that we're controlling chickenpox. So we started giving the chickenpox routinely. And when I say we, I'm talking about the medical system that I was in.
Well, and I think that modern young people don't know that before the chickenpox vaccine, about 400 people died every year in the US when they had complications of chickenpox. So
of chickenpox, yeah. And, things change too. Viruses become more pathogenic. And this is the case for strep too. Like we've had a really bad strep outbreak. I don't know if you have had this, but really bad strep outbreaks in the last 2 years, starting like a year into the pandemic. It was terrible.
I just saw a woman who was hospitalized here with toxic shock syndrome from mastitis.
Right. Do you know if it was staph or strep?
It was not identified, but
okay.
The surgeon who consulted me said she was the most floridly septic patient she had ever seen.
Wow.
And then, had this very edematous red breast when I of course wasn't called to see her until 5 days later. But
yeah.
So they were said, we were worried she was going to have to get a mastectomy, and it was just,
horrendous.
Yeah, it was awful.
Yeah, it's tissue destruction. So the authors did a literature search and they found 6 other cases of invasive group A beta hemolytic strep mastitis, with 5 of those 6 presenting with severe clinical course, like the case I presented. They had sepsis and they had streptococcal toxic shock syndrome. And this occurs because the bacteria has various factors that can induce necrotizing infections, including streptolysin, streptokinase, and other exotoxins, all of which can create tissue destruction. So that's why this particular case, she was already on antibiotics, right? But she still became toxic and had necrotizing fasciitis because it's really the toxins that led to all those symptoms, which are not going to be destroyed by antibiotics. It's the bacteria that secrete the toxins that are destroyed, but the toxins still, and it may be that the toxins just, were just exploded out of these bacteria as they were being killed. The 6 cases in the literature review and this particular case highlighted in this article were all treated with antibiotics before they developed toxic shock syndrome. The breastfed children in these cases that they highlighted ranged from 7 to 14 months of age. So they were young, and we oftentimes don't think about babies having strep throat. We think of them as not having that. It's usually the older siblings. The surprising issue here is that strep throat is actually pretty common, and we don't see this more often. It's estimated that 24% of children under 5 who present with a sore throat have strep, and 5 to 15% of children carry group A beta hemolytic strep as asymptomatic carriers in their throat. So the authors conclude that transmission from child to mother during breastfeeding can induce a group A beta hemolytic strep mastitis infection, as they have demonstrated. The authors talk about prevention, and they say there's really no guidance on whether or not women should continue to breastfeed if a child has scarlet fever, and they're suggesting to not breastfeed in these cases.
Of course they are.
Of course, yeah. And they're citing the reference lab. It's called the Reference Lab for Strep in Germany, which recommends avoiding contact between Strep Pyogenes and any breach of the skin barrier, such as orifices or fissured nipples, because of how invasive and aggressive group A beta hemolytic strep can be. The authors, what's interesting is that authors kind of go back and forth between talking about children who have scarlet fever and children who have Strep Pyogenes in their child's pharynx. as risk factors for invasive group A beta hemolytic strep mastitis. And I wonder if it's more likely going to happen if the child has scarlet fever, because at that point the child is experiencing effects from some of the toxins released by the bacteria. So perhaps those are more aggressive strains than your average, strep throat, where people, the kids will have a little bit of a fever or a sore throat, sometimes not a fever, and they get better, within 8 hours of starting antibiotics. I think one lesson here is that if someone with mastitis is not improving in the first 24 hours, that they be seen by a physician or another provider who's knowledgeable about mastitis, and not assume that the mastitis is inflammatory from overfullness or lack of milk removal. And if they are treated with antibiotics and they're getting worse, they be seen and not automatically switch to antibiotics, because you really need to eyeball these people and see what's going on.
Well, I mean, I think this has really been an issue for a long time, certainly since we have focused more on the inflammatory processes that cause breast pain, fullness, heat, swelling. People are, understanding that not everybody needs antibiotics, but it just boggles my mind that in general, these patients are not seen. People call their doctor, they're called in antibiotics, they're given advice. It is just unconscionable. There's no other, part of medicine where people are blown off to such a degree for an acute illness. And I think that it really does just come back to me. All the people who I've seen I saw a woman this week who had an abscess that ruptured.
Ooh.
She had been seen in urgent care 4 days prior and given an antibiotic. She wasn't getting better. It wasn't until her breast started oozing out. And then even that, she had an upcoming appointment with me. So she just waited until she came to me instead of going to seek more acute care.
Well, and I think part of the problem is that people are not quite sure what they're going to gain by going in to see someone who doesn't know much about the breast. And they may think why should I spend my money on that if they're not going to help me or blow me off?
That's also true. I was part of a conversation where the patient was having a problem, and the OB had reached out to me and said, can you get this person in? And I saw the part of the chat with the patient where the patient had said, should I go to the ER? And the provider had responded, no, they're not going to know what to do.
Yeah, right.
And I think, unfortunately in that case, the provider, who also really didn't know what to do, just sort of was trying to get her in with me, which wasn't working. Even though she didn't quite know, it would have been better for her to bring the patient in and at least eyeball her. It's better for her to call me from the office and say, I see this, what should I do? Rather than just trying to get her in. Because once she's got the patient in front of her, she can give me information that I can then help her with.
Right. And that's basically, I would say as a family doctor, that's what we do. We bring them in, take a look at them, whether they're short of breath or having a fever or whatever, you take a look at them and then you say, let me get the specialist on the phone to see what I should do. But you got it. And so I feel like for mastitis, there's something different about it. People don't want it. It's like a hot potato. I love how you talk about mastitis is the hot potato of breastfeeding medicine, or maybe it's IgM or whichever is the hot potato.
I mean, just the breastfeeding diet. It's the hot potato of medicine. People don't know what to do. And this actually does roll into what I wanted to talk about. So I wanted to talk about the new United States Preventive Services Taskforce final recommendations on breastfeeding. They were published on April 11th of 2025. And
kind of, I don't
know. The statement was titled Breastfeeding, Primary Care, Behavioral Counseling Interventions. And I just want you to remember that it focuses on behavioral counseling interventions later on, and I'm going to tell you why. For those of you who do not know, the US Preventive Services Taskforce, which I might just refer to as the task force, because that's a mouthful, works to improve the health of people in the US by making evidence-based recommendations on effective ways to prevent disease and prolong life. Created in 1984, the task force is an independent, volunteer panel of national experts in prevention and evidence-based medicine. And I put that in because when I started to, do a little research to talk about this, the top line on this said, this is not a recommendation of the government. And I was like, oh, I see. So task force members come from the fields of preventative medicine and primary care, including internal medicine, family medicine, pediatrics, behavioral health, obstetrics and gynecology, and nursing. The preventive services they evaluate are behavioral counseling, screenings, and preventative medications that can prevent diseases before there are obvious signs and symptoms. And I just think that's relevant because one of my soapboxes about breastfeeding is that we need to be screening for risks of problems. But this report specifically highlights behavioral counseling. So in general, the recommendations are based on rigorous review of existing peer-reviewed evidence and are intended to help primary care clinicians and patients decide whether a preventative service is right for a patient's needs, because there are so many different preventative services that exist. If there's not enough information, the task force calls for more research. And I think it's also important to mention that the recommendations impact what services U.S. insurance companies must cover, because the Affordable Care Act said preventative services should be covered without cost sharing by the patient. And then those services that are included are listed out by this task force, WIPSI, which is a women's task force, and Bright Futures, which comes from pediatrics. The recommendation is that their recommendation in April is that for all pregnant and postpartum women, they should be provided with interventions or referrals during pregnancy and after birth to support breastfeeding when they are seen in primary care. So this is really, what should primary care people be doing? And they rated this recommendation as a B, and they've got a system for, depending on the evidence, if things should be A, B, C, D. This recommendation updates the 2016 statement on primary care interventions, and they state that it is consistent with those recommendations. So why is this recommendation for intervention or referral important? And they say breastfeeding has been associated, as we know, with child benefits. I'm not going to go through all the things they listed because the people listening to this podcast already know maternal health benefits. But in the US currently, only 27% of infants at 6 months are exclusively breastfed. And the Healthy People 2030 goal is to increase this to 42%. It also reminds us about some of the variables associated with lower breastfeeding rates, including Black race, being younger than 30 years, participating in the Special Supplemental Nutrition Program for Women, Infants, and Children, which we also often refer to as WIC, being unmarried, living in a metropolitan area, or having high school as the highest education level. They recommend implementing this recommendation and say, to achieve the benefits of breastfeeding interventions, it is important that evidence-based interventions are readily accessible for all patients who are pregnant and postpartum. Behavioral counseling interventions that help increase breastfeeding rates include breastfeeding education and support. This typically includes a formalized program to convey general breastfeeding knowledge and focus on the benefits of breastfeeding, practical skills, and management of common breastfeeding complications. Breastfeeding support can include providing information about the benefits, as well as psychological support and direct support during breastfeeding observations. And it can be provided by a variety of professionals, including nurses, midwives, clinicians, lactation care providers, as well as trained peers. And that really, very broad description is because in the evidence that they reviewed, there was no one clear way to do it that provided more benefit than others. Likewise, it can be provided in a variety of settings, in person or remote, home visit, in hospital or medical office, and interventions may be delivered in an individual or group setting. And it can occur over multiple periods, such as during prenatal, peripartum, and postpartum. Those that occur over multiple periods tend to have greater effects. The patient population that they addressed was really all adolescents and adults who are pregnant or postpartum and their infants and children. And I just want to highlight the fact that in general, the recommendations of the task force in the past has been interpreted by insurance companies as saying that interventions that are provided to the lactating parent must be covered. But I think it's really important to mention that a lot of these interventions are available in the pediatric settings, and those should be covered as preventative medicine as well. Interventions to support breastfeeding may also involve partners, other family members, and friends. And they also call out that the recommendation does not apply in circumstances when there are contraindications to breastfeeding. And in addition to that, the task force did not review evidence on interventions directed at breastfeeding of preterm infants. And I consider that to be an egregious oversight because the percentage of infants who are preterm in this country is actually quite large.
Yeah.
If you consider the late pretermers in that group. Lastly, they mention that they have a section titled Response to Public Comments because a draft version of the recommendation was proposed for public comment from October 22nd to November 18th of 2024. Some comments requested that the recommendation include health system level interventions. And did you put that comment in there?
I did not.
I might have. Might have been.
Did you? I don't know. I did comment, and I don't know. I don't remember.
The USPSTF would like to clarify that it focuses on interventions that can be provided in primary care settings and has revised the title of the recommendation to make this clearer. I like that they didn't change the report, but they changed the title. And I also think that it really goes back to the fact that the title included, counseling. And I think that they also really should include some screening, but I suspect that there is not yet evidence around screening for risk of breastfeeding failure in primary care. And I think that is a huge need in breastfeeding research. So that is my summary of their work and the areas that I think that still need additional work to be done.
Yeah. I guess I would say, and this is what I've told many people, is that the United States Preventive Services Taskforce is very picky about what they think is something that should be done, right? They're conservative. So, collecting a routine urine during a physical, nope. Doing a prostate exam, nope. Doing a physical exam annually, nope. There's a lot of things that we do.
It's because they really are looking at what has randomly controlled trials showing that it has benefit, and they look at the risks. So in this, they discuss the risks of more anxiety and less self-efficacy in the patients who received counseling, and often cost plays a role. And so if you look at how much is it going to cost to run all those urines, and is that going to be a good use of healthcare dollars? I think that is a thing. But I was talking to my nurse a day or two ago about some research she was reviewing for a class, and she was like, it's amazing because the baseline, like the standard group in this study had a home visit. And then there was an intervention group where they did more. I'm like, yeah, the same people that have these amazing programs are the ones who've got research funding to report on them. We don't have either of those things. We're just seeing patients as fast as we can.
Right. Yeah. Yeah. I think it's interesting that they talked about the risk of, people feeling stressed out about, about just talking to them about breastfeeding when perhaps they're not intending to. I ran across the same thing. The previous podcast to this was a Lact Fact podcast that is just published, I think, today. And that was about the new AHRQ, the Agency for Healthcare Research and Quality in the United States, where they reviewed income and child outcomes from breastfeeding. And it was an update from 2007. And one of the things they say at the very end, it listed like all of the different benefits of breastfeeding, basically, or health outcomes, what has strong evidence or what has moderate evidence, what has low quality evidence or low strength of evidence. And then at the end, there's a lot of benefits. Like there's a lot of important reasons why people should be breastfeeding. And in the end, they say, well, you got to be careful when you share this information with people because they might just feel guilty that they're not breastfeeding, and this can be, difficult. And I'm like, I kind of feel like at that point, the people who wrote that don't really understand that we do our jobs in a professional manner, and we don't.
It's just disgusting if you compare it to diabetes counseling.
Right. Yeah.
At the end of the article on diabetes interventions, they don't say, P.S. don't make anybody feel bad if they're overweight.
Right. Exactly.
Like, thanks.
Right.
We know.
Right.
Gotcha.
Exactly. It's kind of like underestimating the skills that we have as clinicians, that it's only, it's like I think your example is perfect. Like, be careful. Like, don't talk about obesity. Don't talk about, the fact that losing weight is important for control of high blood pressure, diabetes, stroke, MI, blah, blah, blah. Because we might.
I think to me, what I've come to understand, and this is, I think, really interesting when it comes to primary care. And I'm kind of curious, like if we think about interventions in primary care, this sort of was very focused on counseling of the patients. But I actually think that you could have an amazing intervention in primary care that was focused on training the providers and the staff to do some things differently, to change the phone triage so that when people have mastitis, they get brought in so they don't wean prematurely because they had an abscess and got hospitalized. But I think that my experience with people counseling around breastfeeding support is not so much that they're worried that people are going to feel bad if they don't want to do it. It's that the provider is going to feel bad if the patient really does want to do it and they're not able to help them be successful. Because no physician hesitates to recommend a car seat. Because if that patient can't afford it, we've got a mechanism. And I think the other really big hole in this study is back at the very beginning when they said, you've got interventions or referrals, they don't specify who you're referring to.
Right.
And there's a huge problem with physicians abdicating evaluation and management of medical problems occurring during lactation and sending those patients to lactation consultants who have essentially 1 year of education. And so they are very well-meaning people who are often very good at things within their scope of practice. But who are we referring patients to needs to be more specific based on whether or not there is this is preventative support referral, like we're going to teach you, we're referring you to prenatal counseling, or where are we referring you when you have mastitis? Because if you're waiting and then it's an abscess and you're referring to breast surgery, breast surgeons almost have no education on managing hyperlactation.
Right. Exactly.
And so I think that while it is absolutely appropriate for this group to stay within their wheelhouse and talking about primary care, they need to be more specific about that. And if that means that we need more research in order for them to do that, they need to call on people to do that research. But this does not show an awareness of the ecosystem of breastfeeding and primary care's role in it. And that, to me, is why it is important to highlight the primary care role in health system.
Right. Do they address it at all about education of primary care physicians? No. Yeah.
No.
Yeah, no, that's a huge issue. Because it's one thing to be supportive and it's one thing to be knowledgeable. And I almost feel that sometimes physicians and other providers who they're very well meaning to be supportive, but then sometimes, the babies don't even get supplemented enough because they're like, well, just keep breastfeeding, it's fun.
Oh, absolutely.
Yeah.
Yeah. I mean, I've seen really babies that were not thriving
Right.
because
Oh,
in
yeah.
an effort to not, interfere with the breastfeeding and start supplementation, which was truly needed.
Yeah.
And they didn't realize that, okay, this parent who had, breast surgery or IVF or PCOS, they're at high risk for not making enough milk. And so if you miss that, and then the baby is doing very poorly, supplementation comes in late, the chances of complete weaning because of the very stressful events are higher, I think, than if you support somebody with low milk production to continue breastfeeding while supplementing, which is a skill that primary care providers need training in.
Right.
It isn't something that anybody taught me to do.
Right.
And it's tricky. It takes extra visits to check the weights and see if we've gone high enough or too high on the supplementation.
Right.
There's a lot of work to do in primary care.
So much work. And you and I are working on that, aren't we?
Yay! It's super fun.
Yeah,
I love it. It's just, so many things to do. I want to take care of the patients. I want to do the research. I want to make sure the advocacy and the policy get done and teach the new generation. And, maybe I'll go home and take care of my own kids occasionally. So
I just think I think the frustrating thing is that our efforts to do this is all happening after they finish their training. And I wish that we could just really get this incorporated in medical school, in residency, just like they leave their residency, they know how to identify heart failure. They know what to do. They're not cardiologists, but they sure can steer the patient in the right direction and get them stabilized.
I think you're right. And I think this, report is a missed opportunity to sort of identify the role of primary care providers in, screening for problems and supporting, behavioral counseling for continuing breastfeeding during supplementation. But I think we're going to need to do the work of what are the specific skills these primary care residents need to be taught. And then when those, different skills are on their board exams is when they actually make it into the curriculum.
Yeah, exactly. Yeah. All right. Well, thanks for update. And I'm imagining that there are a couple things about this report. One is that the last one was 2016. So this is merely an update, right? Just because it was time to relook at it. And then the other thing is that I noticed in the 2016 one, they talked about how doing prenatal and postpartum interventions together was more impactful than just one or the other. And I don't know if they mentioned that this time as well.
They did. They said, multiple interventions at different time points can be more effective. And,
Great. Okay.
And I think the other thing that, I literally could keep talking about this all day. This is going to be my last thing. But thinking about, yes, they have stated in the past that these interventions could be useful. I think it's really interesting to look at so many years after the Affordable Care Act said these are supposed to be integrated. A lot of places, they're still not. People cannot use their insurance to get them. So Our hospital system does prenatal education, but they won't bill insurance for that. And that I think is, it's just another barrier.
Yeah. Yeah. But that's a whole other issue.
I will say it's fun to podcast with you about it. And, hopefully by the time this is looked at, in another 8 or 9 years when they update it, we'll have a little bit more research to push the recommendations in that direction.
Yeah, I think AI is probably going to do it next time. Yeah. Well, that was good. Thank you so much, Karen. It's good talking to you, and I'll see you next month.
Sounds great. Okay. Bye now.
Bye.
For questions regarding this podcast, please contact us through our website at lacted.org. We have other educational projects, including the Clinical Question of the Week, our Little Green Book of Breastfeeding Management for Physicians, and our various educational courses and conferences for physicians and other breastfeeding supporters. If you want to see what we look like, check out our Breastfeeding Medicine podcast Facebook page, where you can post any questions or comments about our podcasts. Thanks for listening, and we'll be back with you in about 4 weeks.